Welcome back to the Oncology Brothers podcast, where Rahul and Rohit go sane, two community medical oncologists. And our goal with this platform is to continue to focus on new approvals, conference highlights, treatment algorithms, and tox check discussions, while keeping that patient in mind that we're about to see next in our clinic. Today, we're continuing our tox check series, where we zoom in on toxicities, dosing, and practical management around these adverse events so that we feel more confident in keeping our patients on these medications safely.
Rahul, a common theme with these tox check discussions has been educating our patients so they know what to expect. And then from our end, being proactive. I anticipate this will come up today again as we dive into the world of PIK3CA or AKT pathway inhibitors for hormone receptor positive metastatic breast cancer, where we have three options approved, that is Inavolisib, Alpelisib, and Capivasertib. And to walk us through some of the common side effects and their management, we're joined by Dr. Neil Iyengar, a breast medical oncologist, and Dr. Emily Gallagher from Mount Sinai Hospital. Emily and Neil, welcome.
Emily and Neil, thanks for joining us. To set the stage and a little background here, Alpelisib was first approved in 2019 for metastatic hormone receptor positive breast cancer. Then in 2023, we got Capivasertib with fulvestrant. This was approved for a broader indication, including our PIK3CA and AKT mutations, but also PTEN loss. And then more recently, in 2024, we got Inavolisib with palbociclib and fulvestrant, which was approved for patients that had progressive or recurrent disease on or after completing endocrine therapy. This particular subset of disease ends up being very aggressive, and here we saw overall survival benefit. But all this benefit is coming at a cost of side effects. We have few class effects here, particularly hyperglycemia, rash, and diarrhea with these medications. Neil, can we start here with Inavolisib, as this was approved in earlier lines? What are some of the common side effects that you educate your patients on and some clinical pearls around this?
Thank you, Rahul, for the question. And that was an excellent summary of the clinical efficacy of these drugs. And Inavolisib, as you mentioned, I view as such an amazing advance for an aggressive niche of the disease. But as you said, there are significant toxicities. And this is where, as oncologists, we're put into the position where we have a very effective agent, but we have to use it in a nuanced way that helps to balance those toxicities. The most common toxicities associated with Inavolisib are certainly metabolic related. We do see hyperglycemia, and there were strict inclusion criteria in terms of who could come on a study because of that hyperglycemia risk. We need to be proactive about managing the metabolic toxicities. Certainly, there are GI toxicities. Diarrhea is the most common, but general dyspepsia, nausea, vomiting, and stomatitis are adverse effects that we need to be proactive about to maintain quality of life. There are dermatologic toxicities that include rash. With Inavolisib, this tends to be less of an issue. With Alpelisib, that rash could be pretty severe and needs systemic steroids, which could exacerbate metabolic toxicities. These are the most common AEs associated not just with Inavolisib, but generally with this class of therapeutics.
Neil, thanks so much for touching on that. And as Rahul stated, and you alluded to as well, that's the class effect where we see hyperglycemia, rash, and diarrhea. Emily, with regards to hyperglycemia, when Inavolisib was approved based off of Inavo 120 study, there was a strict HbA hemoglobin A1c criteria of less than 6 or fasting glucose of less than 126. As a result, managing hyperglycemia rather becomes important. When it comes to our clinic, the first reaction is to get endocrinology on board. But you and I both know seeing endocrinology can take some months. So can you please walk us through your management, or rather practical pearls, in regards to hyperglycemia? And I'd like to get into the dosage and the application of metformin and SGLT2 inhibitors as well, but starting out with hyperglycemia, please.
Yeah, so the most different thing about this medication versus the others was in the clinical trial, they actually excluded most people who had even pre-diabetes. An A1C of less than 6 is actually in the pre-diabetes range, not a diabetes range. Sometimes people don't go into the details of the actual inclusion criteria. One issue that we're seeing is that people are getting prescribed the medication, even if they have pre-existing type 2 diabetes, which was not the people in the study. You can expect in the real world that the way it's going to get prescribed, people are actually going to have higher rates of hyperglycemia than in the clinical trial. That's just one caveat. to notice that within all of these medications, the clinical trial inclusion and exclusion criteria were all quite different. For anybody on these medications, the BMI in this particular study was also a big predictor of who was going to get hyperglycemia. Hyperglycemia was much higher in people with BMI greater than 30. And so that is another thing just to be aware of. If you have people who have obesity by BMI, they are at much higher risk of developing hyperglycemia. In those people, I recommend prophylactic metformin and a lot of counseling related to diet, not to put people on a diet to lose weight. These people have advanced cancer, and that's not the goal. It's really to try and have them get enough calories in, but try not to have an overload of carbohydrates, which is going to really drive the hyperglycemia. Target some things that are often kind of low-hanging fruit, like refined carbohydrates, like sodas, sugars, and the diets and things like that, just to try and help people understand that that really can drive the hyperglycemia, and that we're really not trying to restrict their calories. We're really just trying to prevent the hyperglycemia.
Emily, and with regards to the metformin, do you get them started right away along with the medication itself, or when you see a spike in the glucose? And what dose are you typically going for? And also when to tie in the SGLT2 inhibitors?
I usually start the metformin. Ideally, if you can get the patient before they start on this medication, it would be nice to get the metformin on board first. It's not always possible, but if you can do that, it's good to get it on ahead of time. Partly because you can then sort of distinguish what the GI side effects are. Unfortunately, metformin
Right.
comes with GI side effects as well. The second thing I always do is start low and titrate it up, because if you put somebody on max dose metformin to begin with, you can guarantee they're going to get GI side effects and they're not going to tolerate it. So generally, I start at 500 milligrams once a day. Always take it with food. Don't take it on an empty stomach, because again, it'll exacerbate the GI side effects, and then try and titrate it up to maximum dose as tolerated. Usually I go by 500 milligrams at a time. The extended release version of metformin can often have less GI side effects. And so that is also a good option for people if you think they were going to be at higher risk of developing GI side effects. The SGLT2 inhibitors I add as a second line, or in people who can't tolerate the metformin because it's a GI issues. You just have to be careful with like this population. Again, they're kind of high risk, and so there's an increased risk of urinary infections. And so that's just something I always warn people about, because you don't want to end up giving somebody something that's going to cause an infection. So if they have any signs of any sort of GU infections, I always tell them to look out for it and to call back if that happens, and stop the medication until we, regroup.
Emily, thank you so much for touching on that. And I have to agree, though there was a strict enrollment criteria here with the Novel 120, but we often discuss these medications in the right settings for our patients, even if they have well-controlled diabetes, given that overall survival benefit that we see with Inavolisib. Okay, before moving on to Alpelisib and Capivasertib, as we'll bring these common side effects up again, can we touch on dosing here for a second? Starting dose with Inavo is 9 milligrams daily, but we could consider dose reduction to 6 milligrams, and then another step down to 3 milligrams daily if need be. Neil, when you're seeing these side effects with Inavolisib, can you share on how you decide on pausing and then starting back at the same dose versus dose reduction?
Yeah, absolutely. So the label gives us guidance in terms of when to initiate dose modifications. But one of the points that I'd like to emphasize to provide more guidance context to the label is that, these adverse effects are slightly different in terms of their prevalence between the different PI3 kinase or AKT inhibitors. And, I do find, at least in my experience with the Inavolisib, the rash and the diarrhea are a bit more manageable than, say, something like Alpelisib. So I personally have not really been needing to deploy dose reductions to manage those adverse effects with Inavolisib. Emily alluded to her nice approach to managing hyperglycemia, which I think can also, especially if we're proactive about it, can be very effective for managing the hyperglycemia, which also limits the need for dose modifications. But I do find that the most common reason why I'm deploying a dose modification is because of the hyperglycemia, especially if we're enrolling patients who might be on that upper end of either BMI or A1C at baseline, as Emily alluded to. For diarrhea, I think it's important. We talk about grade 1, grade 2, grade 3, and so on for diarrhea, but it's really all about two things in my mind. One, understanding what the patient's baseline bowel patterns are. This is really important for the nursing staff. Really important to understand your normal number of bowel movements on a daily or every other day, or however many times a person may have a bowel movement. So that really allows us to then judge for that individual what is grade 1, grade 2, or grade 3, because we know these definitions are based on number of bowel movements in addition to your standard baseline. The second point that I'd like to emphasize, as both of you, Rahul and Rohit, mentioned, educating our patients goes into being proactive, particularly for the GI and dermatologic toxicities. Being proactive is incredibly important. If patients are keeping loperamide with them and using it at the first sign of diarrhea, it's much easier to manage the diarrhea that way than if they're waiting and calling in for guidance, and now we're chasing it with Lamodal and other more potent anti-motility agents that then can flip over into constipation. So it's really that education piece. Same thing for the rash. If you notice the rash in the beginning when it's more grade 1, before it starts to become more diffuse or even systemic, it's much easier to treat, and you may even avoid systemic steroids when you educate patients to alert us early.
Thanks so much for bringing up that point of incidence, as we will see that this definitely differs when we're discussing Alpelisib. And that's truly the reason why I have not utilized this agent in some time, especially after the approval of Inavolisib and Capivasertib, as we see hyperglycemia, diarrhea, and skin rash more with this particular drug. Neil, thoughts on side effects here associated with Alpelisib and managing them, please?
Yeah, I completely agree. I think Alpelisib is really being used less and less because we have the other agents, Inavolisib and even Capivasertib, where the adverse effect profile, I would say, is much more manageable. That being said, Alpelisib is a potent PI3 kinase inhibitor with efficacy, at least in terms of progression-free survival benefit. And so again, if we can be proactive about diet, I advise patients to consume a low carbohydrate diet for any of these agents that's less than 100 grams of carbohydrates per day. That can be helpful. We've done a study where we also looked at ketogenic diet, but that's a difficult diet to maintain. That's less than 30 grams of carbohydrates per day. I don't necessarily advocate for that. I think more of the low carbohydrate threshold is more feasible. Um, Alpelisib does have more toxicity. The rash can be more severe. I've had to use more systemic steroids to manage the rash, which then exacerbates the hyperglycemia. I do find with Alpelisib, it is actually important to hold the drug, to wait for resolution of the toxicity before you try to rechallenge, even if you're rechallenging with a dose reduction. My general approach is to reach for one of the other two agents first. If for whatever reason I am using Alpelisib, you have to be even more proactive about diet and hyperglycemia management, and then even more proactive about you want to select the patient who you know is going to call you or alert your staff right away if there's a GI or skin toxicity so you can get ahead of it.
Yeah, even for my practice, I can't remember the last time I used Alpelisib. Emily, as you're aware, hyperglycemia, again, here's an issue, but we see this over and over with Capivasertib, Alpelisib, or Inavolisib. And when we're asking our patients to monitor their sugar levels at home, how frequently should this be done? What's the best method? Should it just be the labs that we draw, continuous home glucose monitoring? Any thoughts here in clinical pros around this?
Yeah, most of the guidelines on this are based on what was done in the clinical trials. And so that's kind of where most of those kind of frequencies of finger sticks come from. If somebody's monitoring at home, I would say from my personal experience, like twice a week at least, finger sticks should be done just to catch it, because generally the hyperglycemia does occur actually pretty early. Like you can see it happening within a few days. They go up from their baseline, and then generally within the first 2 weeks, you will see that they'll become quite hyperglycemic if they're going to develop hyperglycemia. As we said, it is an on-target effect, so everybody will develop some degree of hyperglycemia. It depends on how hyperglycemic they become. Continuous glucose monitors were not used in the studies, but you can buy them over the counter now. If you have access to them, they're a good way of keeping an eye on the blood sugar at home. We do prescribe them in people if they're starting and we think they're at high risk, just because it actually can catch it earlier. And it also gives people a kind of an idea of the pattern. So I find them helpful to kind of help with the education of the patient too, because they can literally see if they eat something specific and their blood sugar goes very high, they can tie those things together with the medication. So although the guidelines are based around finger sticks, I find that continuous glucose monitors can be very helpful in this situation based on my personal experience and the fact that they're much more easily available now. Plus, they're also independent of the finger stick, so it actually can reduce the burden on the patient.
tying in with the endocrinology when possible, but if that is far out, then tying in with the primary care physician helps with these circumstances. Well, with regards to Alpelisib, 300 milligrams daily is the dose that is approved, but then the step down is 250 milligrams and then 200 milligrams daily. All right, off to our last one here, which is Capivasertib, which was approved for PIK3CA or AKT mutation or PTEN loss. Neil, with regards to this drug, sure, we have the hyperglycemia, diarrhea, and rash concerns as well. But interesting was that it's not related to alopecia. Is that what your experience has been? Because that is a quality of life concern when you're talking about patients with metastatic disease.
Yeah, I find that Capivasertib is generally pretty manageable. I've not seen any alopecia in patients that I've prescribed Capivasertib. Even the rash, I've seen some rash, but it tends to be either less common or less severe than Alpelisib, for example. To your question specifically about dermatologic toxicities, I think I've seen less of it with Capivasertib and it's more manageable. I've not seen any alopecia here either.
And one thing about the dosing here, this is very different than what we've seen with the Inavolisib and Alpelisib. This is not everyday dosing. This is 4 days on and 3 days off. So it's very important for us to educate our patients on how to take these medications correctly. And it's 400, step down to 320 milligrams, and then down to 200.
Rahul, but I think the point you just made is so important because it is confusing, the discontinuous dosing. And so we do need to educate our patients. At least in my experience, patients actually find that to be a bit relieving because they're off of the therapy for 3 days and generally don't deal with some of these toxicities on the days they're off. I actually see that as a plus for the drug, that the schedule, even though it can be confusing, as long as we're clear about it, it gives you that little break.
Absolutely. And we see this with other class of medications as well, where they're on 3 weeks on and week off, and that week off can really help those patients to recover. Emily, outside hyperglycemia, can you share some clinical pearls around managing diarrhea? As we see this with PIK3CA inhibitors, you also alluded, which is what we tend to see even with metformin. How do you decide which one's causing what, and some pearls around that?
Before we get to that, I think the other point with this one is just that the hyperglycemia has been less in this studies, as you mentioned, whether that's related to targeting AKT versus PI3 kinase, or whether it's because of this intermittent dosing is not quite clear. But the other thing just to be aware of is that the criteria for defining hyperglycemia were different in this study versus the Alpelisib study, right? So they were actually like glucose cutoffs of like 250 was a grade 3 hyperglycemia in Alpelisib. This one was actually if you start insulin or are hospitalized, that was what grade 3 was in this study. So they're very different cutoffs for hyperglycemia. So I still have a lot of caution in patients on this just to keep an eye out for it. It hasn't been around as long, so we just have to be kind of a little careful. When it comes to the GI side effects, again, mostly the ones that we are concerned about the diabetes medications that can contribute are generally metformin. The other class that's getting used very frequently is the GLP-1 receptor agonist, which can cause a lot of GI side effects. Generally, if somebody's been on those, you could actually include people who were on any treatment except for insulin for diabetes. So most people would have probably been on metformin as a first-line treatment if they had diabetes. And generally, if they were tolerating it well, and then you add in the capi, then basically you can end up with, you can pretty quickly tell which thing was causing what. When you're adding on medication, you just have to be more careful of these side effects. And we don't have enough experience right now with some of the newer agents, such as like the GLP-1 receptor agonists, and whether they will actually kind of worsen the GI side effects that people are getting when they're on the AKT inhibitor. And we're going to have to figure that out over time. But that's a newer agent we're using for diabetes quite a lot, especially in people who have high BMIs. And obviously the interaction with some of the drugs, we just have to be careful about.
And Emily, I like that pearl where you are starting metformin or some of these medications beforehand so one can decide which is causing the diarrhea itself. Well, we've covered quite a bit. Before we close, Emily, any final thoughts or key takeaways for our listeners so we are more comfortable in managing these side effects in our settings?
I think patient education is key. You're helping them understand it's an expected side effect. I think an important thing to realize is that they're almost definitely going to get some hyperglycemia. Some of the symptoms of hyperglycemia can often be confused with side effects of the medication as well. And so things like, I think, people suffer a lot of fatigue and they don't realize it's the high blood sugar causing the fatigue versus the cancer or the cancer medication. Helping people understand what's happening to them can really help them work with you to reduce these side effects.
Neil, any thoughts before we close?
One thing that I will say, certainly the education piece, as well. But I think also educating our nursing staff to know when to escalate, and so what immediate recommendations like diarrhea management can be provided to the patient. We will have a paper that has been accepted for publication coming out in NPJ Breast early next year, which is expert consensus on the management of side effects or adverse effects associated with Capivasertib. This is generally applicable to the other drugs in the class as well. So a lot of what we've been discussing will be summarized in written form very soon.
Absolutely. Educating our patients, educating our staff, and on our end, being proactive is the key. This conversation has been incredibly helpful, and I feel more comfortable in managing these side effects with Inavolisib, Alpelisib, and Capivasertib. Neil and Emily, thank you so much for this fantastic discussion. For our listeners, let's go over a quick recap. Today, with Dr. Emily Gallagher, an endocrinologist, and Dr. Neil Iyengar, a breast medical oncologist, we touched on common side effects we tend to see with PIK3CA and AKT inhibitors. Rohit, what are your key takeaways?
Right, Rahul. What we discussed was a common theme that was hyperglycemia, rash, and GI symptoms, which is associated with all these three drugs, that is Inavolisib, Alpelisib, and Capivasertib. But what we discussed was that the incidence definitely differs. What I'm walking away with this is close monitoring for hyperglycemia, whether that's labs, regular glucometer, or continuous glucometer, which is extremely important to catch that glucose trend early before patients become more symptomatic. You want to intervene early on with medications such as metformin rather than waiting for these patients to see an endocrinologist months later or being off the drug when we could have managed this in our clinic itself. Rahul, what do you want to take away from today's discussion?
Yeah, Rohit, I agree. Patient education on what to expect and being proactive on our end is how we started this whole conversation today. Besides hyperglycemia, rash and GI side effects should also be on our radar. Often antihistamines can help with rash. If need be, topical steroids can also be useful. And then dissecting what is causing that diarrhea is important. Is it the metformin or the PIK3CA inhibitor here? Thanks for tuning in. This Tox Check episode on PIK3CA and AKT inhibitors in hormone receptor-positive breast cancer. Be sure to check out our other Tox Check episodes, challenging cases, and conference highlights. We are the Oncology Brothers.